All right, so we're gonna get started. Again, I have the pleasure to introduce this session 3, Stepping Stones in Aftershock Recovery. And I have the pleasure to present Dr. Juan Ortega-Legaspi. He's an advanced heart failure and transplant cardiologist. He's also a physician scientist. He holds a PhD. He also works extensively at the ISHLT. He's recently a fellow there, one of the first fellows from Latin America to have that honor. And he's going to talk about in-hospital cardiac arrest impact on cardiac shock care. Thank you, Juan.
Well, hello everyone, and first of all, thank Dr. Hernandez and the organizers. It's a real pleasure being here. You guys have an amazing facility and have done really, really cool stuff here, so it's a real honor for me to be here. So let's get started. So I'll get started with a quick case, just get to the point. 27-year-old young woman with limb-girdle muscular dystrophy, chronic idiopathic cardiomyopathy that has progressed to end stage. Eventually came for one last admission, was put on inotropes, repeated ICD shocks, and just to keep the long story short, ended up being listed for heart transplant. And then, good news, an organ is available, so everyone's happy. Then we had a call, it's around 8:30 p.m. She's about to go to the OR sometime in the early morning next year. They're planning to procure the organ, all that good stuff, and she goes into VF arrest, quite unfortunately. So these things do happen. So let's go about what's the scale of the problem with in-hospital cardiac arrest, cardiogenic shock. So it's not uncommon. Right? It's not uncommon, and then survival is of course not great. Compared to cardiogenic shock in general. Like if you have cardiac arrest, your mortality is much higher. So, and I want to say, some of the things in cardiogenic shock and cardiac arrest is what we in Spanish would call verdades de perogrullo, which is this truths and truths that are sometimes too obvious to say, but they need to be said, but they also highlight why doing research in this area can be so difficult. These things happen too quickly. It's of course obvious that if you have cardiac arrest, you are in worse shape than if you don't have cardiac arrest. But this needs to be studied and needs to be put into the statistics to be able to fully understand what are the causes and how can we revert it and make it better. So, in the case of a myocardial infarction, patients that develop cardiac arrest obviously have a higher mortality than cardiogenic shock alone. Again, one of these that sounds obvious but needs to be put together. And then we know something that is not necessarily so obvious, but if you have a non-shockable rhythm, you're in worse shape than if you have a shockable rhythm. And then most studies and the target population include patients with myocardial infarction, and that is not, of course, all the patients that we see in real life, as some of you who take care of these patients might know. So we know that with the AHA in 2025, the survival is around 23 to 24%, and out of those who survive, around 80% have favorable neurologic outcomes, which is something that must be included as these patients lose end organ perfusion. So eCPR is when you use VA ECMO, so biventricular support, biventricular full cardiopulmonary bypass, when you fail to return circulation with CPR alone. It's a bridge to diagnosis, treatment or reversible causes, recovery or heart replacement therapy, and it allows for other diagnostic and therapeutic interventions like coronary angiogram, PCI, etc., which CPR alone will not necessarily allow. And we see that as these technologies become more and more available, not just nationwide, but worldwide, as we see by our friends in other countries like Mexico and the rest of Latin America, that now this is being implemented in a wider way, in a wider fashion around the world. When you have patients with conventional CPR, you see that you don't necessarily achieve normal cardiac output. It's estimated somewhere you only achieve it in around 30% of the cases. It's obviously very hard to tell because it literally depends on the patient's constitution and literally how hard you pump. So, it's a little bit of a who knows kind of situation in real life. And of course, the longer it goes, again, sounds obvious, less probability of survival. And after 20 minutes of CPR, your chance of survival are actually very, very low. And of course, it is inherently traumatic, and you cannot treat or do anything while you're doing it for the most part. There might be some exceptions, but for the most part, CPR will not allow it. But what are the results of CPR? Because the way I'm framing it sounds like putting someone on ECMO might just be the silver lining in getting someone to come back. But the reality is that the data out there, it is quite mixed. You look at the ARREST trial, and it's a lot better. ECPR versus conventional is a lot better. But when you look at other data like Inception or the Prague therapy, while there is some improvements in survival, at 180 days, there's no improved survival with neurologic benefit in this particular cohort. If you use Shockwave rhythms, there is an improved. So the data is rather mixed. We still don't know exactly, and we don't understand it to the full extent to know whether it applies to everyone. And here comes another message that we're going to be emphasizing a lot for the next few minutes, which is to select the correct patient, which of course it's always easier in something that I always teach my fellows and people in the ICU. Doing this analysis in retrospect is always a lot easier, but when you're there in the heat of the moment, the patient's coding, sometimes you just do it, or sometimes you just don't. And there's always the question, well, did we do the right thing? And it's not so easy to answer. In the ELSA registry, survival is around 29%, so it gets close to 30. So pulling all this data, we get a number needed to treat of about 5. You do get a better chance of having a favorable neurologic outcome if you do it right. And of course, it's better if it happens in the hospital than if it happens outside of the hospital. Some things to consider. So this has been studied with its limitations, because of course, again, this happens very quickly. It's hard to carefully select the patients and get it done in a standardized way. There are some favorable results, like the ARREST trial, in which there was a survival benefit. No significant benefit in a different trial with out-of-hospital cardiac arrest and Inception trial. The Prague out-of-hospital cardiac arrest trial didn't really show significant survival with favorable neurologic outcomes at 188 days. And if you pull the data kind of similar of the graphs we just saw before, there is definitely a signal to improve survival when you do this right. And as a result of all these trials, there's a score now that can be used, which still calls for refinement for the same reasons that I have been mentioning. And interestingly, part of the score here includes even the time of the day when it happens. If it happens in the middle of the night, you lose points. You do much worse if this happens in the middle of the night. It includes the cost. For instance, surgical patients are more favorable than non-surgical patients, like Dr. Erhard explained so elegantly earlier today. So things like that are important to consider. And here it's also included the shockable versus non-shockable rhythm. So when we compare the outcomes between inpatient and outpatient cardiac arrest, we of course see that in inpatient you can do it much quicker. There's better survival. You tend to have more etiologies. Out-of-hospital protocols tend to be more limited and more specific about which patients to do, which ones not, whereas when you're in the hospital, sometimes you just do it because, well, in reality, we've all been there, it's there, so when in doubt, you just do it, life is life. Whereas in out-of-hospital, the out-of-hospital crews and emergency services have very specific either trials or protocols to see which patients to include or not. This is basically the selection criteria, less standardized in the hospital versus more defined in the outpatient, in the out-of-hospital setting. And of course, the cannulation is done in the pre-hospital or emergency room as opposed to the cath lab or the ICU when it's done in the hospital. Again, some of those things that may sound pretty obvious, but it's important to underline and remember. Patients do more favorable if it's a witness arrest, if it's a shockable rhythm, if it's an ischemic cause, and quick myocarditis. If there is a reversible cause that can be fixed very quickly, usually ischemic PCI, or in the case of pulmonary embolus with thrombectomies. Not surprisingly, younger patients do a little bit better if you do it quickly, if they haven't been in shock for a while, so they have low lactates and they haven't really start going into anaerobic metabolism. And if all the other organs work. Again, some of these like we call, again, these perogrullo truths, or as we call them, or these truisms, are important to underline, as obvious as that might sound, but they need to be studied. And of course, if you've been down for who knows, they're not in a telemetry unit and the patient's down, and then at some point a nurse walks in and the patient's down, well, that patient's less likely to do well. Non-shockable rhythms, prolonged CPR, If you have a high pre-arrest lactate, meaning the patient has been longer in anaerobic metabolism, a non-cardiac etiology with worse end organ function, valvular abnormalities, or different comorbidities. And then, of course, there is the issue of what ECMO does to the physiology. We know that, and it's been also very elegantly explained earlier today, it increases LV afterload, it increases LV distension, and very importantly, it increases stress in the wall. So you can argue that ECMO doesn't really promote recovery. So how do you fix it? Well, it sounded pretty obvious. Let's unload the ventricle, put a balloon pump, put an impella, do a surgical vent in the surgical cases when you have access to the chest. And that sounds pretty obvious, and we'll do it. We have all done impellas in institutions like this one where we have the resources. But if you look at the ELSO registry, so far with the data we have, it turns out that it really doesn't necessarily change outcomes all that much. Does it make sense to do in the right cases? It does. But we need to learn more about what LVL loading is going to do and how this sort of level of support promotes recovery or not. And then, of course, you have to manage it. It's not about putting a patient on ECMO and everyone goes to bed. You have to follow the hemodynamics, make sure that they're on the right pressures if they need it, make sure that the end organs are getting perfused, which is ultimately what you want the device to be working for. You're substituting the heart and lungs so that everything else gets blood while you allow the other ones to either recover or get exchanged. I mean, just in a very simplistic way. There is some data that keeping the patients at 34 to 36 degrees Celsius might improve survival in the case of cardiac arrest. And then, doing very frequent assessments for cardiac recovery, weaning trials, and then decide which patients we think are going to recover on those weaning trials versus those that should be escalated to heart replacement therapy, whether it is with an LVAD or heart transplantation. And of course, these pumps, as we all know, they're not perfect. They clot, they generate strokes, they generate a number of problems, North-South syndrome, etc. So you need to control anticoagulation, control the pump, etc., etc. And then you need a program like the ones you guys have successfully built here, which is you need essentials. The ECMO program needs to be there, needs to be grown up, needs to be available 24/7. This is the kind of thing that you can't really have on business hours. It needs to be activated very quickly, ideally within 60 minutes of arrest. There needs to be a team, and then you do need to have ideally a framework of which patients you're going to offer. Not, of course, the extremes of the patients are always easy. The 110-year-old patient with metastatic cancer is probably not a good candidate compared to the 25-year-old athlete that comes in with myocarditis. But, of course, there's everything in the middle. It's never so easy, it's never so obvious, but having at least a framework which patients to include is important at an institutional level, not just in general in the literature. And then you need to have the adequate training. We need more randomized controlled trials, as difficult as these trials might be. It's very difficult to select the patients. It's very difficult to enroll the patients and to have the patients provide informed consent because, it's always hard to consent a patient or a family member of a patient when the patient is getting coded, right? So, those things, they sound obvious, but it's the reality of these trials. We need to redefine our scores to try to use them quicker and get more reliable, and that's going to come with more data. Ultimately, these scores come from data, so we need more data to create better scores. Understanding LV unloading a little bit better in order to see which patients are going to recover better and use these tools more in a more targeted way. Use other measurements for monitoring, and then expand to the community, etc. So what happened to our case? Let's just try to see what happened. So in reality, the patient got eCPR. The patient did not respond to the first round of CPR. And to be honest, I was there. It looked dirty. It was like, oh my, this didn't look good, to be completely honest with you. The transplant was canceled. You don't want to transplant in those circumstances. The organ wasn't there, so that would have been a recipe for disaster. Not surprisingly, creatinine skyrocketed. The patient was sedated, and then we decided that was a wait-and-see kind of situation. But then, there was a young patient. The kidney functions recovered. The patient started making urine. The patient woke up without neurologic deficits, which was, of course, very reassuring, and got listed and transplanted 10 days per VF arrest. So the reason I put this happy case instead of the potentially other 75% of unhappy cases that don't necessarily do well is that we do this for a reason. These cases can do well in the adequately selected patient when these things are done in the right setting, sometimes you can have a very favorable outcome. So it is worth doing. What you guys are doing here to get all this done and to get it off the ground to provide these services to the community here in Tulsa is great, and it's to look for cases like this. And I will conclude in just 10 seconds. Just the takeaways. You know, if your heart arrests and you have cardiogenic shock, it's bad, you know, obvious, but important. This is a good strategy to improve perfusion and see what's going on. You know, we need select criteria. Timing is critical. If you're going to do it quickly. We need to care about the LV distension and unloading, and we need an infrastructure and a system to make this work. So once done, I'll be happy to take questions. Thank you very much.
Thank you, Juan. That was an excellent presentation. So now I have the honor to present Rachna Kataria. Rachna is a colleague and good friend, member of the steering committee and lead for the cardiac shock working group. Comes from Boston at Tufts University, and she's going to talk about ambulatory stabilization on temporary support with a focus on counterpulsation. So thank you, Rachna, again for being here.
Yeah, thank you so much for the invitation. What a beautiful day in Tulsa for my first trip. You guys are extremely lucky to have recruited Jaime, who's been a friend for over 4 years now. Just excellent friend, mentor, clinician, father, from what I know. So really excited for all of you and the program that you're building. So I'm just going to dive right in, and I hate alarms and pagers, so I'm going to panic if this goes off. But there's an unmet need in cardiogenic shock, right? We've talked about that since the morning. Cardiogenic shock mortality remains elevated depending on the data set that you look at. The numbers range from 30% all the way up to 80%. Long-term data is lacking. That's where we really need more research, is to better understand what's happening to these patients in the long run. Survivors of cardiogenic shock, based on our own experiences, anecdotal experiences, some data that's now emerging, they have persistent myocardial dysfunction, so they may come back to you with a heart failure readmission. They may have other end organ dysfunction that may or may not improve. Frailty is a big problem, and then neurocognitive impairment and whether or not they can recover from it. So survival is not the same as recovery. The heart may have survived, but in what shape or at what cost? The traditional paradigm in a lot of the CICUs is rescue the patient from a state of shock, which is important, sedate and immobilize them to minimize complications, focus on escalation of temporary support versus readiness to wean, again, important, and then think about an exit strategy. But what we need is to think about stabilization. We need to think about optimization, extubate, ambulate, improve nutrition, and prehabilitate these patients. We need to think about end organ recovery other than the heart. Which other organs can we recover? And therefore, functional preservation of these patients. So with that in mind, let's talk about ambulatory stabilization on temporary support with a focus on counterpulsation. Balloon pumps are not new. I've read this beautiful book, and I recommend it to you all, about the Every Second Counts, the race to the first heart transplant, and it beautifully outlines how the first balloon pump was used. And this is, I'm told, this is Dr. Adrian Kantrowitz, that's what Google says, in 1967, and he's holding up one of the first, balloon pumps. You don't really see it well against his white coat. But it's been around for a while, and it's traditionally placed through femoral access. We want to make sure that we're not obstructing any of the branches of the aortic arch. The balloon, as was previously mentioned, inflates during diastole, so that corresponds with closure of the aortic valve, and then it deflates right before the aortic valve opens so that there's no obstruction to that ejection. The waveform depicts exactly what we just discussed. So with diastole, or the closure of the aortic valve, which corresponds with the dicrotic notch, the balloon will inflate, and it inflates rapidly, so that creates this column of pressure and displaces blood that's comparable to the volume of the balloon to the peripheral circulation. And then right before systole, right before ejection starts or the valve opens, the balloon should deflate to allow for decreased SVR and therefore improved cardiac output. So again, by diastolic balloon inflation, we're amplifying the Wynn-Kessel effect, and then presystolic deflation helps us restore VA coupling. The response to a balloon pump depends on pump-related factors, so where exactly is the pump positioned? Is it in good place? volume of the balloon that we're using, because it comes in a few different sizes, the frequency of inflation, 1-to-1 all the way to 1-to-8 on certain models, and then the timing of inflation and deflation needs to be optimal for a given patient. But it also depends on patient-related factors, such as their intrinsic blood pressure, heart rate and rhythm, because again, we struggle with balloons in rapid AFib, for example, the compliance of the aorta, peripheral vascular resistance, so what are you working with? Are you working with high resistance or not? As we mentioned, if someone's vasoplegic or vasodilated, probably won't have a good response to a balloon. And then again, it also depends on whether you're treating heart failure shock versus AMI shock. So the first randomized controlled trial of balloons was also, 16 years ago now in 2010. This was the IABP Shock 1 trial, only 45 patients. That's so cute in this day and age, right? So this balloon pump in 45 patients randomized 23 and 22 to the balloon pump arm and the standard of care arm. And what they found was, it was interesting. They said this was associated with modest effects on reduction of the Apache score. So they're looking at the patient's overall critical care illness that you try to capture with the Apache score in the CCU. And they found a modest effect, but then obviously this was a really small group of shock patients, and so the trial essentially was inconclusive. But it did pave the way for the IABP2 shock trial, which came 2 years later, and it enrolled a lot of patients, 300 in both arms, but again failed to show benefit of balloons in AMI shock. These patients could receive the balloon right before or after revascularization, and early revascularization obviously had been, cemented as like the right thing to do for AMI shock based on the shock trial. So this was an add-on to that. In heart failure shock, though, and those of us who practice, CCU medicine or heart failure cardiologists, we love the balloon pump. We think it works. So these are ideal PV loops with and without a balloon pump. The PV loop in yellow is the loop without a balloon, and the one in blue is the one with a balloon. And what you see is that the leftward shift of the arterial elastance, the red line that you're seeing, let me try to point that. Oh, never mind. So that leftward shift essentially means that the balloon is resulting in a decrease in afterload, which thereby is resulting in an increase in the width of the pressure volume loop or increase in stroke volume. But not all hearts and not all failing hearts are the same. So again, here on the left, you're seeing a heart that is terribly failing, and then on the right, you're seeing a heart that has somewhat of a preserved physiology. So a heart that's terribly failing is going to have a decreased or lower ESPVR, which is the inotropic state of the heart itself. And if you compare the two hearts, and obviously these are idealized PV loops, but if you compare the two PV loops, you see that for the same reduction in afterload, a failing heart that does not have the intrinsic contractility is not going to be able to augment stroke volume as a heart that still has or is still on your Frank-Starling curve, if you will. So there's a difference. Not all hearts will respond the same way. With that in mind, a group in Colombia looked at balloon pump response in patients retrospectively, and they, prior to executing this study, had said, we're going to look at the augmentation in cardiac output in all of these patients, and the patients whose cardiac output ends up in the top quartile, we'll call them the super responders. Let's just see what we find. So they look at all patients in the CCU, all heart failure patients, and they get outputs using a PA catheter before and after activation of a balloon pump. And actually, they find that augmentation with a balloon is not just the 0.5 to 1 liter that we tell ourselves it is. It could be all the way up to 2+ liters in the right patient. So you can see that kind of augmentation in super responders. And then they looked at who these super responders were and found that super responders were patients who had an intact RV. Not a surprise to us now, for those of us using this balloon in our CCUs, we find that it is not a right-sided support device. You must have a fairly intact right side of the heart to be able to gain benefit from a balloon pump. And then other retrospective studies have put together what we think are predictors of best response to a balloon, and those include having an index that is low, but it's not severely reduced, a PAPI that is preserved, again, marker of right-sided function, SVR that is elevated, so we have some vascular resistance to work with, a preserved pulmonary artery pressure, and even an increased wedge pressure, if you will, because that is essentially the preload for the left side that the left side can then move along, and then a heart rate that is not greater than 92, obviously, is based on studies, but the patient should not be tachycardic in order to have a good response to a balloon. Why are heart failure patients, or why is a balloon better suited for heart failure patients? Again, in heart failure shock, our goals are decongestion. We're trying to achieve afterload reduction and improve VA coupling that has been lost as a result of the increased SVR for a weak heart. But in AMI shock, when the patient's just had an insult to the myocardium, you're really trying to rest the heart. So you don't want that heart to have to augment output in and of itself. When we use it preoperatively, that's a different situation when we're trying to improve coronary perfusion. But when we're talking about AMI shock, I'm thinking of this as an injured myocardium. There's a really dramatic picture in my head right now. And we're not wanting that heart to do more than it needs to. We want to rest it and we want to unload it as best as we can with a microaxial flow pump. So we've looked at this in the Shock Working Group registry. We've looked at outcomes of heart failure patients versus AMI shock patients that did have a balloon. So we started with 886 patients who had a balloon as their first device. 400 patients were heart failure shock patients, and approximately 400 were AMI shock patients. And you'll see that 33% of heart failure shock patients with just a balloon could be bridged to native heart survival, not recovery, survival. 27% of those patients could be bridged to replacement therapies with a balloon. And then the percentage death was about 13%. 27% of the patients with heart failure shock did require escalation to another device. But then when you look at AMI shock, in AMI shock, the native heart survival was 44%. So again, despite the European guidelines, despite the balloon pump shock trials, we are using it in AMI shock, something to note. We're seeing about a 44% native heart survival with balloons alone in AMI shock. We're seeing 2% bridging to heart replacement therapy. That's not surprising. And then we're seeing about a 19% death within these patients. But when you look at survival free from device escalation in heart failure versus AMI shock patients who started off with a balloon, that was certainly much better in your heart failure shock compared to AMI shock patients. Speaking of heart failure shock, randomized control trial, we finally have one, the ALT-SHOCK 2 trial. This trial was designed such that patients would receive routine early balloon pumps. And if someone achieved a VIS score of 20, they would automatically, it was mandatory to then be escalated to MCS. In this trial, what they did, which was better than a lot of the other shock trials that we've had, except for maybe the DanGer trial, they did use SCAI criteria to classify these patients. They used the CSWG SCAI parameters to assign these patients to SCAI stages C, D, and also they had some SCAI B patients there. But they did not phenotype these patients. They did not really have any hemodynamic data on these patients. They didn't look for the super responders to try to enrich the trial with patients who might respond and then compare those patients to balloon pump versus no balloon pump. The trial was in fact interrupted early because it was felt to be a futile trial for no benefits seen with a balloon. But did we really expect it to be a successful trial? I don't think so. I think, again, for those of us using balloons in heart failure shock patients, it would have been much more helpful to enrich the trial with patients that we think might respond better. And we just don't have that data. So again, I wouldn't put the balloon in the garbage just yet. Now that we've talked about balloons and how they kind of work, let's speak about ambulation, right, which is part of this talk. So ambulatory balloons, again, initially it was the surgeons who said we can, again, use a vein graft, sew it into the axillary artery, and use that as an access site for balloons, and thereby ambulate patients, free up the groins, make them walk. This was published in the year 2000, and then almost 12 years later at the Houston Methodist, they presented a novel percutaneous, completely percutaneous insertion of the balloon pump through the left axillary artery once you've identified it using brachial access, and obviously in the cath lab using contrast. Doing so means you don't need to go to the OR, you don't need a vein graft, you don't need surgeons, you can do this pretty much any time of the day. And also you don't need the kind of sedation that you need for someone making a trip to the OR. In the Shock Working Group registry, we looked at our patients. Did any of our patients have femoral balloon pumps? Because I think this might be a good time for a disclosure right here that I don't think I've seen one used since my fellowship days at Montefiore. We had a balloon pump that we used and it was actually published for the wrong reasons. It migrated completely into the LV. So I'd love to hear from the audience your experience with using axillary balloon pumps. But we looked at our registry and we said, let's see how many of these axillary balloons do we have in the registry. And again, the print is a bit, it's a little difficult to read, but our registry obviously has more than 6,000 shock patients. And then what we did was we looked at how many patients had balloons. We had 300 patients who had an axillary balloon at any point during the hospital stay because it's uncommon for it to be the first device you receive. And then about 700 patients had a balloon pump femoral as their first device. We found that only 10 to 12 patients had an axillary balloon for AMI shock. So again, we decided to restrict this analysis to heart failure shock only and continued with 244 patients with axillary balloons and 313 patients with femoral balloons. And what we found was that the time to implant and duration of support, particularly the duration of support, was much longer in patients who did receive an axillary balloon. So it was 9.6 plus minus 14.6 days with an axillary balloon compared to a femoral balloon, which was 4 plus minus 4.5. Outcomes, again, not surprisingly, femoral balloons were mostly used in patients being bridged to native heart survival, whereas axillary balloons were typically used for patients being bridged to replacement therapies. But again, escalation to another device was not different. So again, the balloon works when it works, and you don't necessarily need to escalate based on where you place it. Benefits of ambulatory balloons, obviously walking patients, which then means you can focus on nutrition, you can focus on reversing frailty, but then challenges are vascular complications, device migration, as I just described, and also limited support, which is, again, that is just the balloon itself. It doesn't have to do with where it's placed. So my final takeaway is balloon pumps are physiology-driven pumps, and that's why it's important to place them in the right patient at the right time, and also be considerate of the pump factors that we just discussed. The trials haven't shown any benefit, but I think the trial design might be to blame. And axillary balloons help us reframe support in a way that it can be more ambulatory, restorative, and we can be more strategic about the patient's exit strategy. But I'd love to hear from the audience and the panel how many are actually using axillary balloons and what your experience has been. So thanks again for the invitation.
Thank you, Rachna. So now I have the pleasure to invite to the podium Sophia Earhart. Sophia is a trailblazer in many fields, including pulmonary hypertension. And as you can see, the common theme here has been hemodynamic profiling and understanding. And now she is, not only a lead for pulmonary hypertension at Baystate, but also the regional director of heart failure. And I'm very happy that she's in Western Mass, part of my life, a good decade of my life. And my daughter was born in Western Mass, so I'm very attached to that area or latitude of the world. And I know that she's doing an amazing job with that program, along with Nate. And we're just so honored to have you. So thank you for being here.
Thank you so much. Yeah, it's truly a pleasure to be here with friends and colleagues and see this beautiful hospital on a beautiful day. So you've heard a lot about why we're here. Mortality and shock remains high despite the etiology. And while there's a lot of programmatic success and hope on the horizon, really over the last decades, we haven't moved the needle too much. So in talking about Impella 5.5 and recovery, I want to touch on a few things, namely who benefits, why it works, when to use it, what it enables, and really what success looks like. And you've heard some of this earlier today as well. So let's start with a case. And this is a 34-year-old female, 8 weeks postpartum, who presented to one of our outside hospitals with a STEMI. Because of that, she got lytics and then was transferred to Baystate, where she got an angiogram. And you'll see the right coronary looks fine, and we don't see the left main at all, basically. So she had a left main dissection that clearly wasn't treated with the lytics. So she had progressive shock, profound shock, had an Impella CP placed, and they attempted to revascularize her, but these are very challenging procedures. And she had incomplete revascularization and had VT storm in the cath lab. And so now we have a patient with refractory shock despite an Impella CP and vasoactive support. So what happened? They called my husband, and she was escalated to an Impella 5.5 and was able to be rapidly stabilized. Her lactate normalized, her renal function recovered, and the arrhythmias stabilized. So what's our goal here? with a 34-year-old female with a newborn, the goal isn't just remission, and it's not just survival. So when we're taking care of this patient, I think it's important to speak the language so we can have the same vision going forward. And true myocardial recovery, while that's really the gold mine, in her case might not be feasible because she had such a long ischemic time. So ambulatory stabilization with a 5-5 really changes the patient from this storm of inflammation, high filling pressures, decreased tissue perfusion, to a stabilized window where we can look at recovery and next steps in terms of decision, focus on nutrition, ambulation, GDMT, and end organ perfusion. You've heard in the earlier talks too how 5-5 is different. It gets full LV unloading, up to 5.5 liters of flow. Patients can be ambulatory. You can have it for a longer duration of support and much, much less hemolysis and improved renal function. So is upfront Impella 5.5 the best approach? And that wasn't the case in our patient, and often it isn't the case. And so this is from the Cardiogenic Shock Working Group looking at 5.5 alone versus other MCS device. And not surprisingly, when you escalate devices, you have more complications, which again goes back to what our goals for patients. Is it just survival, or is it recovery with fewer complications? And that's really what it is. So patient profiling from the beginning and knowing a trajectory can be helpful. But in her case, her shock was so acute that there wasn't time to mobilize a 5.5, and so putting a CP in the cath lab was definitely the right decision. So back to Miss Y. She was transferred from Bay State, and I was working at Beth Israel at the time, and so I accepted her, and we tried to recover her. Unfortunately, it was unsuccessful. Also, she had recurrent VT. After a little bit of an Impella repositioning, she had AI, and so she was hypoxic, not able to fully decongest, and she was just really spiraling. And the 5.5 provided meaningful support, but really it wasn't getting her out of the dark, so to speak. So she was listed for transplant and got transplanted the next week and is doing incredible. So that was really great. So, looking at a larger cohort of patients, and we're so fortunate to have leaders of the Cardiogenic Shock Working Group, founders of the Cardiogenic Shock Working Group, which really has defined this field. That's just one case, but looking at a broader range of cases, what happens to these patients? A lot of these patients do well with 67% survival. A lot of them are going to heart replacement therapy. And while native heart recovery or native heart survival is possible, it's really not the majority of patients. So it enables multiple clinically meaningful pathways. And the ability to go on to heart replacement therapy or native heart recovery or survival also differs by shock etiology. It's important to know that up front so you can have informed discussions with patients, their families, and awareness of the typical trajectory. But many of these cases are very different. So when should we start with a 5.5 versus escalate to a 5.5, de-escalate, shoot for recovery, versus when will these patients need heart replacement therapy? This is a really active area, and as you've heard many times today, the emphasis is on early support, continuous reassessment, and a multidisciplinary team. And there's many guidelines now that talk about escalation, de-escalation, and reassessment. So in addition to our case, Impella can be used as a platform for stabilization and recovery, often in high-risk valvular cases, which you've heard about earlier, PCI and VSD closure, which you'll hear about later today as well. You've also heard about Impella 5.5 in high-risk surgery, where it can often be utilized and is particularly beneficial when you have hemodynamic optimization pre and a plan, so it's not just kind of the type 3 where you're salvaging the patient, but really keeping them strong throughout with good perfusion. So what about Impella as a platform for GDMT optimization? So this is also very close to home for me. In the figure on the left, you'll see Jacob Abraham's group at Providence, where I worked previously, looking at GDMT with Impella 5.5 decreasing mortality, and those without GDMT with worse survival. There's another large center group, and this was just a single center, showing how GDMT can support overall recovery and midterm outcomes with, actually in this group, 95% survival at 180 days. And you'll see in that context clearly patient selection is going to come into play. I had the opportunity to see Stavros recently at ISHLT, who's another leader in this field, and he was discussing Impella 5.5 as a bridge to the gold mine of GDMT. And I think what's important to recognize about that bridge is that we don't have best practices yet. And there's, well, in some ways it seems relatively straightforward. It's not by any means. A lot of times we're worried about hypotension affecting renal function. And then if you don't know the trajectory, if someone might go to transplant, you probably wouldn't be wanting to start them on Entresto. So when we use renin-angiotensin system, GDMT versus not, can be nuanced in this population. So it's exciting to know that there's going to be the INTEGRATE study, which will objectively look at this in a multi-center post-market study of focusing on heart failure cardiogenic shock, patients who aren't optimized on GDMT. And there's also relevant exclusion criteria. And so if they're going to transplant, those patients won't be enrolled. And then the goals are pretty concrete in terms of 4 pillars initiated by hospital discharge, up titrated to max target by 90 days, and then a 90-day follow-up. So in the future, we'll have more data to define recovery protocols, but this is what we use at Providence, kind of walking through based on their MAP goals, based on their fluid optimization status, where to start and how best to support them with the goal of recovery in the right patient phenotype. So I want to go through briefly one more case to highlight the phenotype of heart failure, cardiogenic shock, and Impella 5.5. I saw a 60-year-old male with long-standing, over 10 years, non-ischemic cardiomyopathy who had been managed by the private practice group, and we had really limited data prior to him presenting, but his ventricle was severely dilated. He was actively using alcohol and tobacco, had worsening shortness of breath. His PCP up-titrated as beta blocker for resting tachycardia, and then essentially he presented in decompensated shock with biomarkers through the roof, biventricular dysfunction, EF 30% with severe MR, meaning his EF was really less than 30%, and hemodynamics with clear cardiogenic shock and elevated filling pressures and elevated lactate. Initially, he did okay on inotropes, but then a few days later, he had worsening urine output despite escalating inotropes. His renal function was getting worse, his lactate was rising. And so then heart failure was consulted, and the question became, is he a candidate for advanced therapies? Now, in someone with active alcohol, tobacco use, and pulmonary hypertension, although it could easily be decongested, this doesn't look like a transplant candidate. So the question is this a durable VAD candidate? And that's really hard to answer in the acute setting. So it definitely requires further evaluation. And another important plug for a multidisciplinary team, does he have the social support? Is he going to be able to be abstinent? Does he have prohibitive other end organ dysfunction? So we assessed his liver. We want to assess his RV function off of inotropes. Once he's decongested, is his RV going to perk up? And because the team wasn't ready to commit him to an Impella 5.5, because when you commit to Impella 5.5 as a bridge strategy, the question is, what's the out? And if we don't think this severely dilated ventricle can recover, then in some ways we may be prolonging his course without having a solution. And so to allow us a little bit more time, we did a left axillary balloon pump first with the hope of improving his nutrition, ambulating him a little bit, and having more time to see if he might be a durable VAD candidate. He declined with the balloon pump, not surprisingly. He was undersupported. His phenotype, as you've heard, was more dramatic than could be treated with a balloon pump, but it allowed me to talk to the team and give this patient a chance. So he was escalated to an Impella 5.5 with the goal of bridging to durable therapy, knowing that he wouldn't survive without support. So this allowed him to get out of bed and walk. His other organs recovered. He actually had refeeding syndrome from protein-calorie malnutrition because he hadn't been eating well because he had been drinking so much. And over a month of optimization, we finally got him to where he needed to be, and we were able to bridge him to a durable device. And he had a little bit of a challenging post-op course, but not surprisingly, given how long he had his cardiomyopathy. He needed a temporary RVAD, but that was able to be weaned. And now he's almost a year out, doing well, completely abstinent, and really advocating for the durable program because he's had such improved quality of life with it. Actually celebrated his birthday and had a virgin pina colada. So why this works: early recognition of disease progression, open communication, temporary support used thoughtfully, coordinated team, and patient-centered decision-making. So I'd just like to reiterate what you've heard today, that we need good people and good systems, plus data to save lives, and I think this conference is one step closer to getting us there. So thank you.
Thank you, Sophia. That was wonderful. So now I have the honor to present Mohit Paduja. Mohit is a leader in cardiac shock. He's an interventional heart failure specialist. Has built a program in Oklahoma University, a couple of hours from us. And I met him as a fellow, and I see him now leading the state in complex cardiac shock cases. And it's really an honor to have you here, see you grow, and always been a great partner and friend. So thank you for being here.
Well, thank you, Amy. I'm very excited of you having me over here. And I've been talking to you about Oklahoma, I think 3 years back, and telling you about all the challenges. And I'm so glad that you're here and we can partner on something together now. So yeah, I just modified a little bit on talk, which is about ambulation, and we're going to talk about it. But I thought it is important to understand how the combination of ECMO and Impella is more about rescue support to the LV unloading. I think that's the talk which I would like to focus on. I do not have any disclosures except that I am both interventional and heart failure transplant trained, so you will see PV loops and cath images. All right, so the objective of my talk today is about basically understand how does ECMO works, how does ECPella works, and what is the physiological basis and hemodynamics behind it, what is the indication and when we should unload these, and what are the timing of unloading these, because that's the major question. What is the right time, and should we put Impella up front, should we put it later, and what is the evidence supporting these documentations? So as we are all aware about it, there are two ECMO circuits which can be placed, which are peripheral and central. Peripheral ECMOs, which goes through these large bore sheaths going into your femoral vessels. There are risks involved because of the amount of obstruction these big sheaths can cause, and that's why we are understanding more about the vascular complications. And then there is central ECMOs, which I think have been talked about by our surgeons already in previous talks, how they can benefit with antegrade flow, but also have their own challenges. So for the major portion of my talk, I will be talking about as our combinations of ECMO with Impella with peripheral VA ECMO. And as you see these ECMOs, when we talk about these peripheral ECMOs, the flow which comes from the ECMO actually is going retrograde against your LV, which we are all aware about. And these flows, if you have an LV which is beating, there is a watershed area which will cause most of the time in the descending aorta. But if you have a very bad ailing heart, these afterload can really be challenging to manage. And these can result sometime in increased afterload causing decreased aortic valve opening, which results in LV distension, causes worsening pulmonary edema, decreases your coronary perfusions, and then that also increases risk of thrombus formation. A very good example is over here. If you see this patient, a real life, he had a patient who formed aortic root thrombus after an ECMO, and you can see even in the LV there is some thrombus formation. And once this occurs, I think it's very difficult to come out of this. And that's why it's very important to understand who are these patients where unloading of these ventricles will be important, because once they form these thrombuses or they have high afterload causing pulmonary edema, you also increase your risk of Harlequin syndrome after placing an ECMO with Impella in these patients. So now to understand a little bit of hemodynamics of behind this, I'm very glad people have already talked about pressure volume loops. So my job is easier. I'm only going to explain the 3 points which is important in this is, we remember our end systolic pressure volume relationship. The ESPVR is your LV contractility. The width of the graph is stroke volume, and then we look at the diastolic volume and pressure on the curve, which is down. And one thing is important on the figure on the right is this pressure volume loop area is what tells what is your oxygen demand of your heart muscle. How much of your heart is pumping actively and how much it is pumping at baseline, because they always have some amount of volume, which is called potential energy. And these curves are important. These area groups are important for your heart overall physiology and mechanics. So what happens in a patient with cardiogenic shock? In cardiogenic shock patients, as we talked about, the LV contractility decreases, so your end systolic pressure volume relationship curves goes on to the right, it comes down, your stroke volume drops, your undiastolic volume as well as your diastolic pressure increases. So basically, you're moving the curve right and upward. Now, we talked about the pressure volume loop area. That kind of increases the oxygen demand on your heart. And let's see what happens when we place an ECMO in these patients. So when the same shock patient, the curve on the left is on the right ventricle, and on the right with the red color is in the left ventricle. As you can see, when we start putting ECMO in these patients, the curve starts moving rightward. You increase your systolic pressures. However, you decrease your stroke volume because LV ejection can go down. And this in turn can also increase your end diastolic pressure and volume, which increases the overall wedge pressures as well as the load occurring on your heart. And that can result, unfortunately, sometimes in increase in RV afterload as well. That's something to remember depending upon the overall underlying etiology of the heart as well. And this was theoretically, as shown over here, showing that your RA pressures drop with ECMO because you have cannulas which are draining blood. It can increase your wedge pressures, it can increase your left atrial pressures and PA pressures, and it can improve your aortic pressures, but in turns can also increase your LV and diastolic pressures as well. And this was proven in an animal model when they put an ECMO coming from the right to the left at baseline to the 5-liter flow. You can see the left ventricle volume increase as the flow of the ECMO was increased. The aortic pulsatility drops, and your aortic pulse pressures drop, but the aortic pressures increase. That is, you're having a good mean arterial pressure, but the LV ejection is going down. So this is important to keep in mind. So that's one of the reasons when we see this physiology that we start talking about should we unload or vent the LV, which is a completely different phenomena. Venting can be done passively. Reducing an ECMO flow is one way of doing it. Inotropes are used, vasodilators are used, and there are places where these can be done in a right group of patients. However, the patients which are very, very sick LVs, they need some kind of unloading mechanisms. And currently in today's day and era, we have different ways of doing it. We have our surgeons who can put surgical cannulas. We have a pulmonary artery cannula which can be placed. There are left atrium cannulas, a name called LAVA ECMO, where we can put both the cannulas in the left atrium and right atrium and help unloading the ventricle. Then there are atrial septostomies. And the two devices which are very, very commonly used nowadays is Impella and intra-aortic balloon pump. Intra-aortic balloon pump causes unloading and have more effect on venting, according to me, because the amount of support it provides is a little bit lower. And these are the paper which shows that ECMO venting with the INI mechanism can work. This is a study which was published back in 2019, where they did a meta-analysis on 4,000 patients. If you look on the top, all those studies are on intra-aortic balloon pump. And there are like 6 studies on Impella, and then there are other mechanisms of venting these patients. And when they compiled the data together of all these different mechanisms, they did find people who were vented or unloaded had overall better survival than people who did not got unloaded. So how does Impella with ECMO works? Because this is a talk I'm focusing on. So I just told you about how when we put an ECMO, your curves move towards the right side. As the curve moves onto the right side, you have increased afterload as well as increase in myocardial oxygen demand. So when you put an Impella, you see these triangular curves which are formed. Basically, you're losing your isovolumetric relaxation and contraction because you have continuous flow from LV to aorta, and the curve starts moving leftward. It actually can also improve your perfusion pressures a little bit more. So this is very, very important because this leftward shift of the curve helps you decrease overall wedge and left ventricular and diastolic pressures. It also increases your pulmonary artery capacitance, which I think is very, very important when you have a patients who have biventricular failure. And this has been proven. The hemodynamics and physiology has been shown into mechanical levels. How does it work at cellular level? This is a study which was done in pig models from Dr. Kapoor's lab, where he looked at it and found out the patient who had acute MI in pigs, and they put an ECMO, they have a higher infarct size. There was a further drop in mitochondrial function in these people. And those who were vented with an Impella, actually the infarct size decreased, and the mitochondrial function was also improved in these patients. So LV unloading can work. This is a study which was from Germany, including multi-center patients from multiple centers in Europe. It was a propensity match study of 255 patients in each arm. And what they found out was the patients who got ECMO with Impella had a better survival overall in general over a time period of 5 years when they collected the data. And this was true for all kind of patients, older adults, whether the patient, what etiology of cardiogenic shock did not matter, whether they presented with cardiac arrest or not, depending upon the lactate level also. So overall, we found that the survival can occur in these patients in almost all group of patients if they are placed at the right time, in the right group of patients. But it does increase complications. This is the same study showing almost every single group of these patients also have higher bleeding and limb ischemia. But that doesn't mean it affects survival. What it does tell us is a great indication. If we can find pumps which can decrease bleeding and limb ischemia, we may have better survival than what we already have right now. So I think this is a great opportunity for us to work on how we can make protocolized way of decreasing these complications to improve our outcomes. And then they also looked at the same group of people, look at the timing of Impella with ECMO. And what they found that the people who got Impella within first 2 hours actually had better outcomes in comparison to those who got after 2 hours or they were used as a bailout approach. So I think this is very, very important to identify these patients with ECMO who may crash early on, and unloading these ventricles will be more beneficial if the Impella is placed early in these group of patients. So what are some of the criteria which you can use to identify the patients who will benefit from LV unloading? Hemodynamics parameters are important, looking at their wedge pressures and pulse pressure. There are echo parameters, which looks at the LV dimensions, LV thrombus, looking at the aortic valve opening, looking at clinical signs of pulmonary edema or ventricular arrhythmias. But according to me, if you ask me, all these, if you wait to happen, they are too late. So 3 criteria which I feel is very, very important for me in the cath lab, and I'm going to show a case for this, is look at the hemodynamics, their wedge pressure. If its wedge pressure is high, their pulse pressure is less than 15 or less than 20, and they have absence of aortic valve opening. These are the ones I feel will benefit early from Impella. So these 3 are early markers. If we can look at these, I think these patients will benefit the most among all. And then management of ECMO with Impella is equally important because these devices have complications, so they require daily parameters of labs, looking at the echoes on daily basis, making sure the LV and RV dimensions are fine, their septum is more central, looking at the Impella position to prevent hemolysis and suctions, looking at your hemodynamics, making sure their wedge pressures are not increasing, they're maintaining their mixed venous sats, and most importantly, they're improving their lab markers, lactate, looking at the factors such as their LFTs to make sure they are moving in the right direction. And most of these Impellas, when they're put in emergency, are bridge to decision. And in the end, we have to decide whether they're recovery or transplant VAD. And I think that when you start weaning these ECMOs, there are certain criteria, and I always feel you should try to wean the ECMO first. Certain steps which I look at in my own patients when I'm looking at it, and that's what I've written here. First, look at the perfusion and lactate. Have they improved their perfusion and lactate, and we're coming down on their vasopressors and inotropes? I start decreasing their ECMO flows and see how their LV responds to that. Look for the sites of LV recovery on your echo. EF more than 20-25%, LVOT, VTI more than 10 to 12. Looking at their hemodynamic parameters, which shows that the RV is improving. And if the LV is not improving, then we know that we may have to escalate further in some of these patients. And then accordingly, first I decannulate ECMO. and then determine whether I need to remove our LV pump or not. And this is very, very important because Impella can buy you time for myocardial recovery in these patients. And this is very important. If you have an Impella CP which was placed in the cath lab, this is the right time to upgrade your patients to 5.5. And this can be done for both bridge to recovery as well as bridge to transplant or advanced heart failure therapies. And as Sophia mentioned, bridge to recovery is very, very important because once we put Impella 5.5 in these patients, some of them can improve with GDMT. And now we recognize ambulation is very important in these patients. And sometimes these patients may require a prolonged therapy even to recover. And we all know as heart failure transplant physician that our patients wait longer time to get transplants done. So doing a 5.5, providing them the opportunity to ambulate at the same time is also very important so that we have good outcomes in these patients post-surgery. So what is the current state of ECMO unloading? This is the data from ELSO registry. About 26.7% of the patients in 2022 when they looked at I'm going to be done soon, got some kind of LV unloading done, and 17% had Impella. This is an ongoing randomized clinical trial going right now to determine whether Impella versus ECMO will help or not, and we are excited to wait for the results. So I will end soon with this case, which I had, and as I promised you, I will show some cath images. I have to make sure I do that. So this is a 21-year-old female, was called to us from an outside hospital after cardiac arrest. She was 2 hours away, flew to us. She had 45 minutes of downtime, several episodes of VF. She comes to us, and when we get activated, my surgeon, me, and our critical care people are all together waiting for these patients to take them together to do what we need to do. And we have an anesthesia critical care who does TE alongside. She was on the max dose of all 3 pressors. She was basically on rocket fuel, levofed of 0.5, epinephrine of 0.5, ASO of 0.03. Her lactate was 15, her pH was 6.7. Many people thought she's already dead, we should not take her to the cath lab to put an ECMO. But considering her age, 21, we all decided we are going to do that. And this is very, very important. Look at that vessel. We're going to put ECMO cannulas and Impellas in these patients, and we will talk about limb ischemia and bleeding as complications. But these vessels are all vasoconstricted. And then if you look at the pictures of the coronary, which I did, just look at the aortic cusp. The dye is hanging there. There's a dye hanging in ascending aorta, and you also see some AR. That made me realize this patient is not opening her aortic valve. And when we looked at the hemodynamics, same thing which I told you guys. Her LV and diastolic pressure was 30. Look at the pullback, look at the pulse pressure. There is no aortic pulse pressure in these patients. And then we have simultaneously TEE, which we were performing, and we saw that the aortic valve was not opening, and you can actually see smoke into the left ventricle. So in this patient, we decided to put an Impella CP in the cath lab, and you can see LV all of a sudden shrunken in these people. So this is very, very important that we did it in the time 0 instead of waiting. After this patient, she was started on CRRT, her acidosis improved, hemodynamics improved, there was concern of anoxic brain injury on her head CTs. Day 3, she started moving all 4 limbs. ECMO was decannulated on day 5. However, her LV was not recovered, so we upgraded to 5.5, and she started doing some physical therapy at that time. Her LV improved, 5.5 was removed on day 13. Prolonged hospital course, but she did recover after 2 months. I wish I would have put the picture of her. She looks amazing. She follows in my clinic now. And this is her LV before discharge. She was put on medical therapies. For 2 months, she was in the hospital. And it was amazing to see this patient recovered her LV before leaving. And I will be telling you that she had a myocarditis, which was a cardiac MRI done at our hospital, and she also had a genetic mutation with KCNQ5, which could have caused a ventricular arrhythmia. So to conclude, VA ECMO is excellent for circulatory support, but it does increases LV afterload and may cause LV injury. We should identify early the patients who will benefit with the LV unloading. Some of the parameters include narrow pulse pressure, increased wedge pressure, and no opening of the aortic valve. Early LV unloading can improve physiology and outcomes. Transition to Impella 5.5 in patients requiring prolonged support is important and essential, as it helps to find out patients who will have heart recovery as well as heart replacement therapies and can continue to have a good ambulation afterwards. Thank you so much.
Thank you, Mohit. Now it's a pleasure and honor to present Jorge Ortega. I met Jorge as a fellow about 6 years ago in a similar conference in Mexico City. And ever since then, we have become close friends. And been in many research endeavors together. He's prolific in many ways, clinically, as a researcher and an educator. So thank you so much for coming all the way from Mexico City and representing your amazing team in the National Institute of Cardiology there.
Well, thank you for your invitation, Jaime, Dr. Relay. It's really a pleasure to be here. Your institution is so amazing, so many patients, only cardiogenic shock I see today at the CCU. So it's pretty exciting to be here. Well, they give me a pretty tough call, transitions, because we only talk about escalation, but what really means. First, we have to understand the problem, and then I will give a really broad entry about monitoring to exit strategy. So the clinical challenge, to be pretty fair, is up to 10% of MI patients went to cardiogenic shock. The hospital mortality is high, as all the speakers have told all the day. And timing and hemodynamic precision are the things that really are the cornerstone in this endeavor. So refining cardiogenic shock, we have the SCAI classification and SHARC classifications. There is important to have all the consensus and to talk the same language. Because SCAI staging, the first changes occur in the rapid in the first 24 hours. Elric actually showed in the first 6 hours we can transition for SCAI B through all to SCAI D or E patients. So that correlate with outcomes. Also, SHARC consensus gives us that not all shock work the same way. MI can differ for heart failure, as you've seen in the previous talks. Post-cardiotomy shock is another problem, and secondary shock from sepsis or PE is really another problem. So we have to have the same language for SCAI classification, but have in mind that the patient diagnosis is important to know how to perform and how to really transition this patient to a successful end of stage care or to home or to rehabilitation facility. So the first thing is, or the first step in the transition is to early recognize this patient. We have golden hours. If we fail to recognize a cardiogenic shock patient or a patient that really evolves to cardiogenic shock, probably we miss the first step. And missing the first step, it really means a transition to early mortality. So we developed a stop shock prediction. So in Mexico, we have many patients with MI shock. It differs from here, this heart failure. So in ACS patient that you get the hub and spoke centers, probably we have to teach the hub and also the spoke centers to get these calculations really, really quick. And enabling this, we can extract and know which patient will develop cardiogenic shock in hospitalization, and we only really need 13 variables that are really available at the first medical contact, and we validate that in 11 centers outside of Slovakia and in the BETS Israel Diaconess database. And we see that we have a good correlation of 0.87% with these calculations. So after the first step, we had to know what is the hemodynamics of these patients. As we're talking, PA catheter is really a cornerstone, and I'm really fond of PA catheters, but you can also use an echo. So PA catheter in our center is associated with less mortality, 30% less. Also, the PA catheter will give me the information about cardiac power output, the PAPI, the right atrium to wedge radio, and it gives me decision for escalation, de-escalation, and winning decisions. So this is a paper by Luca Baldetti and the team of Italy, where they say which patients should go to a PA catheter if we don't have many PA catheters, or we are restricted, or what kind of monitoring you have to do in MI versus heart failure. As you see, for patients for SCAI C onwards, you have to put down a PA catheter, do echo, bedside echo, but they're really struggling, and the problem is defining the SCAI B, which patient at the SCAI B should get more invasive monitoring, and in which patient that may be an overkill. So for MI patients, you have to look if the patient is tachycardic, is KLIP over 3, you have elevated LVDA or wedge pressure, you have malignant VA tachycardias, you have an LVF less than 30 or a VTI less than 9, you have mechanical complication, or you have an organ failure, probably this patient should go to a PA catheter monitoring. If, for example, you don't have any of these, or you have only one, probably watchful waiting and seeing is the best for the patient, the PA catheter might be an overkill. And why is that? Why I talk about the right timing? This is an editorial, it's in press actually, where timing is everything. There is a dynamic risk prediction about cardiogenic shock. You know, the patient can get an early rapid deterioration or get a progressive decline, or after a successful PCI, as a really early case was shown, the patient go and crash down. So if we are too early, probably we will miss that. And if we are too late, the patient go crashing and not going home, you know? So having the right time, that sweet spot, we have developed many calculations, many models. One is a stop shock that is all of through pre-PCI, and the other Orbi score or sex shock score could help us to define which patients are in high risk criteria to get an invasive monitoring or even a mechanical support. So the PA catheter is more than a number, it's a therapeutic enabled. We don't put down a PA catheter and say, okay, the PA catheter is a treatment. I think after all the cardiogenic shock working group papers, all the CCTM papers, we are past that. Because the PA catheter for the critical care guys, they say the Pacman, the Escape, but they don't really use it in a longitudinal manner. We are the critical care cardiologists. We do see the numbers, we see the truth, and we have the ability with the PA catheter to choose the right MCS for the right patient. So, for all of these measures, we can really lower the mortality. It enables phenotyping, right ventricle versus left ventricle versus biventricular. They are really different. It tracks real time if we have and can read it, and also guides escalation or escalation, and is associated with a 30% mortality reduction. So I also give these talks, and they ask me, did you really teach that? Yes, there are my residents up there putting down an IVP, putting down a PA catheter at the same time in the same patient at the cath lab. These are cardiology fellows, these aren't, you know, the interventional fellows. So every cardiologist should have the core curriculum to put down a PA catheter at the bedside without any fluoro. We have fluoro there because, you know, teaching hospital is nice to see going out. But I can do it in the emergency department, just pre-PCI, putting down a PA catheter in a post-CPR patient, and then going with all the excitement, putting down an Impella down in the cath lab. That I do in the cath lab, but you can do it in any department without any Geico wires, without any technology, only maybe the ultrasounds for being on the safe side. But you have to teach it. And what we come with the Italian-Mexican endeavors, we do this meta-analysis where we actually show there is a lower observed mortality, and with the PA catheter as an enabler, all these studies, 14 studies through the last 10 years, we see a double of MCS use. And it's not that the PA catheter comes along with the IVP or comes along in the package with the Impella, with the CP, with the 5.5. No, it's because we identify correct the patients and say, okay, this patient needs a BA ECMO, this patient will need an IVP, this patient go for 5.5, this patient will go for a CP. But the trade-off is sepsis. And I say my residents, tell me a patient that is dead and gets sepsis afterwards. So that's kind of, you have to get in mind, because Pacman, Escape, and probably the next PACS trial, the double shock, will say, okay, sepsis higher, complication will be higher. Yes, but which patient that is dead will get complications? So the profiling, what I should say my residents, my team, my co-attendings have to follow. Contractility, cardiac power output, left preload, wedge pressure, right preload, CVP or right atrial pressure, afterload, FVR, and right function PAPI. If you have these 5 points, you have the whole hemodynamic picture. But, you know, I'm a critical care cardiologist and I love PV loops. But the PV loops, you only have one way to do PV loops, with conductance catheters. So my master's degree was, can we do without them? Can we enable PV loops for all? So this is a nice study that we presented last week at the ICATLH with 68 patients. We used the PA catheter for the pressures And then I was told, okay, DECO can do volumes, can do LVF. We can derive the PV loops in a single beat reconstruction. So we can do that. And we perform that. We perform with Impala CP and MI, Impala 5.5 and heart failure, and balloon pump MI heart failure, and without any MCS for MI and heart failure. This paper is accepted at ASAYO, it doesn't show there, and the app really works. I really think that the PV loops should be for everyone, and we see different responses by different MCS. And what do we see is that same with Harvey, but translated to the bedside. With really 8 clinical parameters, we can derive all these PV loops and see that true unloading occurs with the Impala CP and MI. And also, in heart failure, that's why we believe in balloon contrapulsation in our heart failure, we see an increased stroke volume, an increased pressure, and a decreased preload compared with other options. So this is a real patient. You can go, this is the version 1.3, this is an old version. So you have the updated version with the clinical panel up there. It's really, really nice. It gives you guidance. I really put, long hours in it. And it say, okay, this is the smart alarms. Congestion will be done in that way. Escalation, they suggest to escalate or de-escalate the patient. So this patient, at the first red map here, you see the patient is really high preload, low contractility state, and then I put down an Impella. At 48 hours, the patient really decongests, unloads effectively, and we can start to de-escalate this patient. So the transition number 2 is the MCS armamentarium. We have IVP, Impala CP, or 5.5, or via ECMO. We have different kinds of support. The really tricky part is to select the right patient and the right time in the right context. IVP is really nice for a first step. Is you can do the 5.5 at 2 a.m. in the morning. Okay, put down an IVP and then let the surgeon get 7 a.m. fresh in the morning and put down the 5.5. Or if the patient is going crashing down, put down a VA ECMO. The really thing is that we treat randomized clinical trials as, the cornerstone, but we have to individualize each patient. Is this patient really an LCL shock trial? Is this patient really a danger shock? Is this patient will go to IVP? So we have to have really that in mind. And also, not all pressors are made the same. The first slide is by Dr. Pinsky, where it looks at contractility versus afterload versus the VA coupling. We want to couple these patients, but what my residents do, I don't understand. They put vasopressin in an MI shock, and I say, why do you do that? Because the pressure is low. Yes, because you had a pump failure. You have to increase the pump. So we look at our data, and we have thinking about this clearance of lactate, complete clearance of lactate at 48 hours, and we look which patients with machine learning, that is the kind of new guy in the street, which patient and which combination is the best for clearing lactate, and then we see if we had influence in mortality. And not surprisingly, the combination had an influence in mortality. The best combination for MI shock patient in our cohort was dobutamine, norepinephrine, and then transition to levosimendan. We have Levophet down there. Here you probably have milrinone. But the message is to first have anodylation, not constriction. And also, I look at separately, the PA catheter actually decrease or increase the lactate clearance. I will go faster. The escalation dilemma, we performed that in the Italian-Mexican database, and escalation is associated with 43% mortality versus 21. But what is escalation? The escalation pathway is what everyone does at the bedside. We have the hemodynamic monitoring, then identify the shock severity, then we optimize the medical therapy, assess response, and try to escalate early. But some patients, we fail to do that. And we fail, and we define the escalation at the first 4 hours. What we find, and that is really interesting, and I say Luca and Guillermo, you see acute kidney injury. We are really, really keen on to put down an Impella and say, okay, this patient will go hemolysis, acute kidney injury. We didn't see any difference if you escalate to inotropes, to IVP, to VA ECMO. So that's kind of interesting. Also, we see major vascular complications go with the device. If you put down a VA ECMO plus an Impella, it will get a vascular complication because of the size of the cannula. And the outcome of escalation strategies is important. We see a tendency, it's not conclusion because it's an observational trial, that Impella is associated with native heart survival and also successful transition to heart replacement therapies. And also prediction of survival. If the patient is young, have a good right ventricle, and also a good urine output, this patient will fare better if we escalate the patient early on. The phase 4 is to optimize the trajectory. Not all patients will go for recovery, as Dr. Racha Kataria says. Some patients will go to continuous care, and some patients will go to advanced heart failure, heart replacement therapies with LVAD or transplant. But we have to try to initiate the goal-directed medical therapy. So this is a patient for my private practice. They call me in, the Impella is totally out, and then I put it back in the cath lab with the fluoros and say, okay, everything is fine. 4 or 3 days after, I go to this aggressive optiterization of heart failure therapy, and I try to follow this guideline by Dr. Tim Baltazar to say which patient I can initiate the Fantastic Four. So the patient come back for the cath lab, and you see the device is malrotated because neuro wanted to do an exam. This patient was post-CPR, and why not? Move the legs, you know? So I have to reposition the pigtail at the bedside without any fluoro. You can do that. Be careful, only put down the to P2. And then through the whole hospitalization at this end slide in your right and downward, you see the patient recover the LVF of 20 to 60% if you initiated aggressive medical therapy with Impella. And it's Impella CP. I don't need the 5.5 because the context of the patient was really acute. So what we've done in the mechanical support era is that we have to have the hemodynamic and the clinical inputs, phenotype, then select the right pathway of TMCS, and then try to remember what is our exit strategy. Is native recovery and weaning? Is durable support? Or the patient goes direct to heart transplant? So you have all of these trajectories intertwining in each other, and you have to select, and you have to remember which patient is your patient. Because many times we want native heart survival. It's not doable for everyone. And in some patients, we have to talk to the family very keenly about futility or palliative care. Because unfortunately, we can offer heart replacement therapy to all. So remember, futility and talk to the palliative care guys is important in our profession, unfortunately. Or fortunately, we have them. Opportunities, we have these 5 opportunities: early risk stratification, universal PAC, maybe echo monitoring for all, timely based protocols. We have to structurize and de-escalate or escalate by patients, and also the post-shock survival programs. So in conclusion, early recognition, hemodynamics, mechanical support, escalation, and always remember the endpoint is not survival alone. It's to have a clinical well-being and try to reconnect this patient with the society. So this is all our team. And remember, cardiac shock is more than one people. It's a worldwide community. Thank you very much.
Thank you, Jorge. Now I have the pleasure to invite Jake Umbel. He represents the physician associates of the Heart and Vascular Institute, and particularly he represents the advanced heart failure team, which is just wonderful. I've been spending time with them for the last 2 months, and their level of understanding of these concepts translated to the bedside, being advocates for the patient, is just tremendous. So Jake, thank you so much for presenting this case and for everything that you do along with your team.
Yeah, thank you so much. It's been a pleasure to work with you the last couple of months. I have just a quick case presentation, so this will be a lot shorter than the last few that you've seen. This was a late presenting MI with free wall rupture. The patient was a 56-year-old female. She's actually a nurse with poorly controlled diabetes who presented with also hypertension and dyslipidemia. Previous history of remote PCI about 26 years ago in the LAD. She presented on December 26th at about 6:50 in the AM, chest pain for approximately 7 days. EKG obtained at that time revealed infralateral ST elevation as well as initial troponin well over 20,000. So she was in a bad way. Hemodynamically stable at that point with a pressure of 128 over 75 and heart rate slightly bradycardic. She was taken emergently to the cath lab and LHC was performed. They revealed a patent LAD stent. And then 100% proximal circumflex lesion, which was the culprit, and they were stented with 3.5 by 20 millimeter Synergy stent. No LV angio was performed at that time. With initial immediate relief of all of her symptoms, she did very well post-cath. And here's an image of her EKG. You can see some of the infralateral changes there. And then next slide here, you can see the culprit lesion of the circumflex, pointed with the red arrow, and then the next image on the right is post-revascularization with that single stent. She did pretty good post-operatively, hospital course day 1, and then at approximately 11 a.m., systolic blood pressures were in the 90s. She was diaphoretic, shortness of breath, no complaints of chest pain, but a repeat echo obtained at that time revealed EF of 40% with infralateral akinesis, but no pericardial effusion was present at that point. And then approximately 1 p.m., Swan catheter was inserted. You can see those hemodynamics that were presented there with a fairly high wedge pressure and reduced cardiac index of 2.2, and so at that point she was initiated on empiric dobutamine at 2.5 micrograms and then diuresed with that as well. Try and offload the LV. Let me go back. And then at 1700, she had a pre-period of hypertension followed by a PEA arrest, which required VA ECMO cannulation at the bedside during CPR, as well as TEE was obtained at that time, showing a large infralateral effusion. She was taken emergently after that to surgery for repair of that posterior wall perforation. And you can see imaging here. It's on the right side of the screen. You can see about midway down there where that LV perforation is. And there's a little bit of motion for you. And then course day 2, on the 26th through the 1st of January, EF was measured at 30 to 35%. She continued to require VA ECMO, low-dose milrinone, and then persistent infiltrates were noted on chest X-ray despite her wedge pressure coming down appropriately to 15. Continued respiratory distress and failure, and she was transitioned at that point to VAV ECMO. And then on the 6th, de-escalated to VV ECMO with a MANTA closure of that arterial cannula site for the VA ECMO, but she did have thrombus that had accumulated in that vessel, and she required a thrombectomy at that time as well. On the 13th, she was decannulated from the VV ECMO, and she was eventually discharged home on the 20th of January with an LV recovery to 50%. So all in all, a very good story for this woman, this patient, and this is just one example of all the things that everybody's been discussing today as far as early recognition and getting these things in place as soon as possible for good outcomes for our patients. And that's all I have.
Thanks, sir. So just please come here and join us in the panel, if you don't mind. We just have a few minutes more before the break with questions. We went through eCPR, we went through, of course, different approaches to devices. And overall, I'm just going to start perhaps with a question for the team that is here, and then we can go for the audience. But from your perspective, we have so much data right now in terms of, the value of early profiling, early intervention, early support. And, how far away do you guys think that we are from a, models of situational awareness that will pretty much take all that role of profiling clinically, hemodynamic, and imaging into a single sort of one-stop image that says this patient is on different sky stages? Are we dreaming about that for the next 10 years? If this is coming up sooner than what we think, based on what we know about different machine learning aspects, do you guys want that as well, or do you guys want to be sure that you adjudicate the level of severity with these different profiling sources? So I will start with Jorge, and then we can make our way here. And again, the question is, do you think that we're there, or that is coming, and whether you would like to be included from the get-go to make sure that you adjudicate that data is correct?
Well, I think we are already there. We already discussed the registries and the databases. We only have to capture the primordial data, and then the apps, the machine learning, everything will pop up. But we have to capture the right data to see the patient, probably not to leave everything to machine, to AI, but for us to input the data and then get and interpret the data. What is, I think, lacking there is the winning or the exit strategy role, the profile for this is the right candidate with the right hemodynamics to go for native heart survival, or this is the candidate that probably preemptively I will screening for heart replacement therapies, for LVAD. Probably we have already seen the clear picture in the first 24, 48 hours with cardiac shock registry data, but we lack where the patient is going. With machine learning and AI, probably we get there, but I don't like to think that, the machine will take over my work. So probably will have to be supervised in a such way by, heart failure specialists, interventional guys, the surgeons. We are at critical care cardiology. Have to be supervised in some way, because there's so many spectrums, but the patient is unique.
Excellent. Rachna, what do you think? Transitions and frontline and all this data, avalanche coming up.
You know how passionate I am about that. I feel like we in this room might be close to there, but then there's 90% of the shock patients that are managed by people that are not in this room. And so, we might be closer than they are, and we together, full, 100% of people taking care of the patients, somehow need to democratize that shock care so that they can at least get to the diagnosis, which is something I loved about the case that was presented earlier today, where the patient was appropriately moved from one hospital to the next because of that awareness of the resources they had and did not have. So I think with machine learning and AI, I always remind myself, garbage in, garbage out, right? So it comes down to the data that we collect. But as far as how close we are to developing phenotyping that's universally applicable, I think we still have a lot of work that needs to be done in the trenches.
Excellent. Mohit.
Yeah, so I think I echo some of the points which have been told before. So I think we have to look into data is one thing. We're all talking over here, all these registry data. I am excited people are talking about shock trials. Are they all VAD transplant centers? Are they all centers which were the top centers in their programs? Are they all the centers who know how to do trials, who have people like you and Dr. Benhouzi who can manage these patients? And that's what we're looking at the results. But those are not the patients we get to see in real life. And that's the major question we have. Are we able to find people and able to serve what they need? And this was a very humbling experience when I came from Washington, D.C. to Oklahoma, is in D.C., I will never have a problem, I'm just going to give one example, of finding a patient in a hospital because there are 10 hospitals around and they will get transferred. They should not be an issue. In Oklahoma, I have to beg to get beds available for a patient who's dying, and the patient is already far away, already delayed, and if he comes to me, I may do something. So the system of care is different. System of care and system of algorithm, making something innova, will that work in Oklahoma? I'm not sure. And I think we have to recognize this, that the algorithm approaches which we have, which are great with all these stages, but they may not work for every single center the same way, or every single country or even the state the same way. So I think we have to be innovative of recognizing the problem for a particular place, and I think that's where some of the things we are realizing in PE world is happening, right? Dr. Friedman talked about that. Now the senates are talking about it, that we want to make a dent in this. I think that's what shock needs. Traumas people have done an amazing job on that. People want to become level 1 trauma everywhere. So I think those are equally important if we want to make differences for patients who are not at the centers which can do all these things.
I agree with that. Juan, what do you think?
Yeah, just real quick. I mean, I agree. I mean, I think we're getting close. It's just about applying all this machine learning, data, algorithms, et cetera, to real life. I think that's one of the key challenges, you know, and it depends on so many variables that's what makes a difference. And also what implicates what kind of quality data we get, because some of the data comes in ideal scenarios and real life is not always ideal. So it's just about crossing that bridge into applying it to the actual bedside, which the variables are crazy.
Yeah, I agree with a lot of what's been said. I love the idea of democratizing care because we all know as clinicians, if someone comes to one hospital versus another, their care is different, and that's so hard to standardize. And in some ways, it's heartbreaking too because it's so hard to make an impact at that level. And a lot of the data we get needs to be interpreted, so I don't think we're that close. I mean, I think that we're good at phenotyping cardiogenic shock and staging it, but in terms of management, like if we had a system that took everything from Epic and then told you what stage and best next steps, I wouldn't trust that data because we know where it comes from and it needs to be validated. So I don't think we're there yet, unless it's the clinician putting it in. And if it is, then you already have a plan.
Excellent. What do you think, Jake?
I agree. I think that we're getting close, but I think we've got a lot of work to do. And like we talked about, you know, AI and the work that's being done there, I think is going to slowly incorporate into our world, but just waiting for the technology to actually get to a place where we can use it functionally and be beneficial.
Yeah, no, I agree with everything. My perspective is that you still need to enhance the front line towards understanding the decision making that is being derived from all these machine learning algorithms, but most importantly, not letting behind the value of human connection before everything else. And I think that has been sort of the theme of all the talks. I mean, we acknowledge the data, we recognize the time-sensitive interventions that need to be done, we understand the physiology behind it, but at the end of the day, you have to have team members talking to each other to make the best decision for that particular patient. And as we are enter the exciting era of machine learning, we're also, I think, entering an era in which people are communicating and finding that that's the only way to have these shock programs sustainable, survivable in a way, and creating platforms for education like today's symposium is a great way for engaging all the different team members that are part of this continuum. So with that, I don't know if anybody has any questions from the audience to this, amazing panel. And yes. Do you mind just introducing yourself and just telling us where you're representing us from in St. Francis?
My name's Sherry Surface, and I'm representing us from the Cath Lab here at St. Francis. And my question is for Dr. Kataria. Sorry if I'm not saying your name.
Yes. Yeah.
Back in the early 2000s, there was a study based in Texas where they were inserting the balloon pump early for septic shock. And it was showing very promising results because back in the day, septic shock was always at 90% mortality. But the balloon pump results were showing that it was helping to get those antibiotics on a deeper cellular level, and it was decreasing the discharge rate to about 9 days for a patient with septic shock. But then all of a sudden, I never heard any more about that study with the balloon pump and what the final outcomes were. So I don't know if you know of anything back in the day or not.
It sounds like the story of the poor balloon pump. Comes and goes in waves, but I have never used it in septic shock. In fact, I'll say much of what I think I know about balloon pumps is thanks to people like yourself in the cath lab and the CCU who, I guess, grew up with the balloon and have used it in so many different situations. Have actually been the people to teach me what I know about the balloons, but personally have not used it in septic shock patients. Anyone?
No.
Yeah.
No, usually it's in a high afterload setting,
Right.
and just to answer your question that you sent for like a lot of the patients that were included in the registry had to do with places that I work with where we had heavy utilization of axillary intra-aortic balloon pump, and I think the patient selection is very important. I think programs that have a high prevalence of listed patients for transplant with hypertrophic cardiomyopathy, with amyloidotic heart disease or restrictive disease, usually balloon pump was the way to go. Now there are more published series, and we have been utilizing recently in Temple transvalvular pumps as well for ventricles that allow for that, just like Osama was showing us. But overall, I think that's the patient population that sometimes is challenging to support otherwise, and we don't want to go ahead and go with ECMO in the context of sensitizing events like bleeding, et cetera. So the majority of the patients at Cleveland Clinic in Florida, and before that, and then after that in Baylor, were usually those restrictive hypertrophic related patients.
I think the question of sepsis is important because, well, in Mexico we don't have, we're lagging maybe 10 years in technology, so balloon pump is, really I think I put it down maybe 50 last year myself. So with balloon pump, what we see is that patients that were supported and then develop mixed shock with IVP to or fare better than those patients that aren't supported at all. But to see that in a randomized clinical trial, or is the IVP is the factor to cash in and put it down just before the mixed shock develops, and which patient will develop mixed shock is a question open for answers. But I think it really, any mechanical support, as Luca had demonstrated in the registry, just before mixed shock develops, it actually helped the patient. I think it's for the support of all organs, not only the heart, because we as a cardiologist love to talk about the heart. We are so self-centered, but in critical care, you also have lungs, you also have kidneys, and the IVP, ECMO, Impella, is really to support everything else while the heart rests. So probably it should be in the direction, the question, not probably the antibiotic, but it's a kind of interesting hypothesis to think about counterposition and penetrance of pharmacologic therapy.
You have a trial to bring back to Mexico, a trial proposal, so that's great. Well, thank you so much, guys. I think there's a 10-minute break, and then we'll go for the last session.